Donor selection, phlebotomy, and testing. Components. These are collected from volunteer unpaid donors. And so why is this important? Well, the volunteer part of it, we don't want anyone under duress being strong-armed into going and donating blood, on your own volition. For the unpaid donor part of it, they feel like if you're paying donors, they could lie about it, which could undermine that safe blood product instead of just doing it as an altruistic, just out of the goodness of your heart. Um, and their eligibility to donate from these volunteer unpaid donors, allogeneic donations, it's going to be determined every day of collection. So we have certain products you can give at different time intervals that we'll learn about, but it's going to be established every time you donate. And that eligibility is going to be established through laws and regulations of the FDA, which says that blood is a drug, the AABB, and CAP. So we know there are portions out there that you can incentivize donors. You can give them things. But the FDA and these other regulation or agencies, excuse me, have said that if you're paying a donor, that blood cannot be transfused directly to a patient. So we know there's programs out there that you pay plasma donors. These can go for making reagents, for making cosmetics, but they can't go directly into, saving a life, basically. Donor screening has three phases: registration, a health history, and a physical exam. So for the registration, we can properly ID the donor and link it to previous records if those are available, if you've done it before. We can then look at previous test results or other relevant information to make sure that you're suitable for donation. These records are retained indefinitely. We can see the list on page 301 and 302 for items that are confirmed by registration, such as the donor's full name, the gender, the date of the last donation, the unique identification, race, all these things that are kind of in there. You're also given some pre-donation education materials, which describes the risk of infectious diseases transmitted by blood transfusion. Some people get confused and get scared about this. Not that you can get from donating blood, but things that you could give someone by donating blood. Signs and symptoms and high-risk behavior associated with HIV and AIDS, and possible side effects and risk associated with donation. So in the health history, this is done to determine if a donor is free of diseases that can be transmitted to a patient, if a donor can tolerate collection process without significant complications. Have you ever had any history of these things that may cause us a problem today? Questions are asked confidentially, which encourages donors to answer truthfully. Not too long ago, we switched from having to ask someone in person to say, have you done this, have you done this, to it's a completely online thing. You're just clicking boxes. These questions are regulated by the FDA and the AABB, and we a lot of times call this the DHQ, or the Donor History Questionnaire. Donor deferrals must be handled tactfully. The reason for the deferral must be explained. And a bad experience can cause the loss of a donor. So what you don't want to do is, shout, "Yo, bro, you got hepatitis, you can't donate," because not only is that a HIPAA violation, it's not handling it tactfully. So you don't want to make anyone, feel bad for stuff they have going on. But you need to explain them why they can't give blood. It may be something as simple as like, you're not quite in the window for giving blood you gave too recently, stuff like that. So then we have questions to protect the recipient or the person that's going to receive the blood. So we're going to ask the donor about exposure to diseases that could be transmitted by blood transfusion, any medications or vaccines that could affect the patient, any high-risk behaviors they may be involved in, their military service, where they've traveled recently, their criminal history, their sexual behaviors. These questions are updated frequently. Sometimes the wordings change. Sometimes if there's you know, an epidemiology research thing that needs to have certain questions asked about blood transfusions, they will ask in there. The use of an interpreter may be necessary, and usually they want a non-related interpreter for honesty because some people don't like admitting certain things to family members. So if we look on page 306 to 308 on tables 13.1, 2, 4, and 5, we're going to see reasons for deferrals. For indefinite deferrals, different deferral periods for different things, and they're categorized into time intervals. We have temporary deferrals, 2 weeks, 4 weeks, 6 weeks, a year, 3 years, and then permanent or indefinite. So for the physical examination part of the donation process, we'll look at the general appearance. Do they look sickly? Are they sweating? They look like they're not suitable to give blood. Then we want to have a hemoglobin of greater than 12.5 grams per deciliter with a hematocrit of 38%. The temperature is not to be over 37.5 or 99.5 degrees Fahrenheit. For their blood pressure, the systolic needs to be less than or equal to 180. The diastolic needs to be less than or equal to 100. The pulse needs to be between 50 and 100 with no irregularities. This can be lower if the donor is an athlete. Hard to say below 50 sometimes. I know sometimes our phlebotomists that if it's below 60, they'll check it again just to make sure. And we want to have a minimum weight of 110 pounds or 50 kilos. You will see this information again, and it may be asked you to recall it. Hint, hint. So confidential unit exclusion. Donors could confidently inform a blood center if their unit should not be used for transfusion. If they just completely lied through the entire process and secretly knew that they had a terribly infectious disease or shouldn't be given blood. This process was rescinded by the FDA because the evidence of the effectiveness, was minimal. Either the donor, never pulled through with it, or it was never fully processed to say like, hey, pull that unit, because the communication wasn't where it should be. Informed consent. A donor must sign a written informed consent to allow their blood to be collected and used. The donor must sign a statement that shows an understanding of all donor information, and the donor is informed that they will be notified of test results if indicated. They're never happy about the notifications of test results, especially with infectious disease. So at the donor phlebotomy, we definitely need to identify the donor, have proper bag labeling, arm prep and venipuncture, adverse donor reactions, and post-donation care. So the donor's identity is confirmed at each step of the donation process. You're also going to inspect both the antecubital areas and check for skin lesions and IV drug use, which we know is a no-no for donation, and is going to begin the process of best vein selection. And you would be surprised with how often that you need to confirm the donor's ID at each step for people trying to switch people in and out and have people not be themselves. People are crazy. For bag labeling, we have a primary bag, and all the attached satellite bags are with this primary bag. You have sample tubes and a donor registration form are labeled with a unique ID number or the unit number. All going to have that on there. These are all traceable back to the original donor registration record, which will have that same number on there. It is barcoded, which is machine readable, and printed, so it's eye readable. For arm prep and venipuncture, the appropriate site is selected, which is usually the antecubital vein. Hopefully it is. That's the less painful vein to donate from. The skin is then disinfected with a 0.7 aqueous scrub of iodophor to remove the surface dirt and bacteria, and a preparation of a 10% PVP, which is povidone iodine. The iodine is applied at the beginning of the intended venipuncture site, working outward in concentric spirals. It is allowed to air dry for 30 seconds before covering with a sterile gauze. Chlorhexidine may be used if there is an allergy to the iodine. With the automated processes of knowing how much that the blood needs to be donated in the bag and weighing it as it's going, they actually have a thing to punch in on a machine that will actually, time this for them. So a little bit more of the arm prep. A tourniquet or blood pressure cuff is inflated to 40 to 60 to make the vein more prominent. A 16 gauge needle is attached to the primary blood bag, is inserted into a large, firm vein that is free of skin lesions. Sometimes this may be a 16 or 18, but it's mostly a 16. The usual donation time for a unit of whole blood is 8 to 12 minutes. You can try to rush it and go faster, get your best time. 2 to 4 sample tubes are collected for testing, for do our infectious disease testing. The needle is removed from the donor's arm, pressure is applied to the site, the arm is elevated, and a pressure bandage is applied. You guys should know a lot about this from phlebotomy, but this is donation process. So we also have to look for adverse donor reactions. Are they having any vasovagal reactions, such as sweating, rapid breathing, dizziness, nausea, syncope, which is passing out? If this happens, we're going to remove the tourniquet and needle, and we're going to give an immediate treatment by our trained staff. If you look at page 313, at table 13.7, gives you adverse donor reactions and the appropriate treatment for these reactions. For post-donation care, the donor is given instructions to avoid alcohol and tobacco immediately after leaving, because that's a real quick drunk, and to drink extra fluids for a few days or at least for the next 4 hours, because you lost a good bit of plasma volume in that process, which is one of the most common reasons for adverse reactions. Is coming in dehydrated, which will definitely help you pass out. You want to be cautious of dizziness and fainting that may occur, especially while driving or operating machinery. And you want to inform the blood center if any symptoms persist. So the fluid that you lost replacement begins in the donor area. They're usually going to give you drinks and snacks are provided, and the donor is checked prior to release by trained staff. Total fluid volume is replaced within 72 hours of donation, but the iron replacement takes a little bit longer. This is why we must wait 56 days until the next whole blood donation. Make sure to take note of that one. Quick funny story about the first time that I ever donated blood when I was in college. There was some sorority fraternity having a little competition. I had an early class, hadn't eaten, hadn't drank anything. It was probably like a 7, 8 a.m. class, and they were trying to snag me before I went in, and I was like, okay, let's get this over with. The donation process itself was uneventful, but it was afterwards. I was like, man, at least I get some orange juice and a cookie and get to class. And so yeah, they had me sat down, and I'm sitting there, and I look in the corner of the room, and it just goes real far away, and like I feel the darkness closing in, starting to get tunnel vision, and the next thing I know, someone's like standing over me, looking like, hey man, are you all right? I said, yeah, I think I just passed out, and it was rough, and yeah, totally should have eaten, drank, had no idea. I was dumb. Anyway, for autologous donations, this is a voluntary donation for a donor's own use. You may do this prior to surgery. If they don't expect to use a whole lot of blood, you may have a religious reason that you can't receive blood from another person. So a lot of times these people do an autologous donation. The disadvantages to it, it does have a predisposal to anemia because you are losing blood prior to going to surgery. There's usually a high wastage rate because they may, say, we need 2 units of surgery, and, the 2 units are only there for a worst case scenario. So a lot of times they never use them. There is an increased cost that goes along with it because it's a little out of the ordinary, so other things have to go into it as far as like keeping it with the tested units but sequestered in its own self, tagged certain ways. And you may have an adverse reaction to the donation process depending on what your clinical state is that you may be going into surgery for. Some of the advantages of an autologous donation, though, is it does prevent transfusion-related disease because you're donating your own blood. Obviously, it's going to prevent alloimmunization because you're receiving your own blood, and it will also prevent transfusion reactions. 4 types of autologous donations. We have the preoperative, perioperative, which is at the same time of operation, which uses automated cell savers, intraoperative, hemodilution, and postoperative. For the preoperative autologous donations, blood is drawn and stored prior to anticipated transfusion. This may be a few weeks before surgery, or this may be frozen, especially if you have a rare blood type. If you are ever in need, we know that we have your blood. So again, rare blood types are good candidates, or people that have antibodies to high incidence antigens. If we know that it's going to take searching the country, or your siblings aren't compatible, a lot of times these people will donate their own units because they know that they have such a hard time getting them. Excuse me. We had 2 separate cases where a lady had a sister that she was donating for. The sister passed away, and so now she donates. They're not autologous units, but she knows that there really isn't anyone in the area that has that type of blood. So mostly, therefore, whoever needs them is what she said, which is a great altruistic thing to do, because if she is in need of blood, it takes a great deal of searching for it. The other situation we had it was an autologous donation, was kind of a autologous directed donation. We had a pregnant lady that had a very high frequency or antibody to a high frequency antigen, and her daughter needed blood right after she was born. So it was, you're not supposed to give blood when you're pregnant, but we had to have special doctor's orders to do this, and was able to transfuse her daughter with a unit of blood, and it was allowing us to store a ton of sample to do additional testing with when we needed to. So again, there's the doctor orders. the informed consent, just like a regular donation. They want the hematocrit to be greater than 33%. Sometimes doctors will kind of go back and forth on this one. They want a minimum of 72 hours between donations and 72 hours prior to surgery. Again, it's labeled a little different. It says it must say for autologous use only. The other blood's labeled, allogeneic donations. The ABO and RH are performed on the unit. And for the most part, it is transfused outside the collecting facility, and when it is, it's going to be tested for the regular hepatitis B surface antigen, the HIV-1 antigen, the antibody to HIV-1 and 2, the antibodies to HCV, the antibody to hepatitis B core, and syphilis. And it cannot cross over to general inventory. Why is this? Because it's labeled for autologous use only. Cannot label it for something that it's not, can't use it for something that it's not, because it's a drug, it's been prescribed. We can't just give that to the regular population. For directed donations, potential recipients recruit their own donors, which are usually family members. You hear Aunt Susan has a surgery coming up and you want to go donate for her, which is all well and good, but there's no evidence that it's any safer than an allogeneic donation. The donor requirements and testing are the same as for any other donor. These units may be crossed over into general inventory because if Aunt Susan ends up not needing the surgery, or the doctor says, well, we don't need those units anymore, we can then put those in regular inventory. An additional cost usually applies for a similar reason, that these are directed donations and we got to make sure that the paperwork's a little bit different and that these can kind of stay sequestered through the process so we don't lose them if you happen to get a unit directed donor to you. Some patients do this because they feel like directed units and autologous units are less expensive than a regular unit of blood, how they charge it, but it's definitely not. You don't save any money. And I wouldn't want to price skimp if I needed blood transfusions anyway, but that's neither here nor there. For hemopheresis, more likely you're going to hear this be called apheresis. We kind of talked about this a little bit before, but we have whole blood removed from the donor, and the desired component is separated out and stored for transfusion, while the remaining components are returned to the donor. You can do leukapheresis, plateletpheresis, plasmapheresis, and erythrophoresis. The plateletpheresis donors need a platelet count of at least 150 microliters. You need to have at least two days between donations, or 48 hours. You cannot donate more than twice a week, and they limit it to 24 donations per year. With therapeutic phlebotomy, this is performed to withdraw blood from a patient for medical reasons. This can help treat symptoms of polycythemia, hemochromatosis, or porphyrias. The blood is not generally suitable for transfusion. For one reason, it's technically not a voluntary donor. Usually your doctor says, hey, we need to go get a therapeutic phlebotomy to treat your polycythemia, which is just kind of interesting because this kind of harkens back to the day that you used to go get bled. Every once in a blue moon, somebody might have one of these issues, and it may help treat the symptoms with it. Now, the FDA has cleared hemochromatosis to be given to general populations, but the donation center that you go to has to be cleared by certain FDA criteria. For donor testing, we know we need to do the ABO and RH. An antibody screen is performed. Hepatitis B surface antigen, hepatitis C antibodies, hepatitis B core antibodies, HCV nucleic amplification testing, or nucleic acid testing, anti-HIV 1 and 2, HIV NAT, anti-HTLV 1 and 2, RPR, West Nile NAT, and the most recent one is Zika NAT testing. For the ABO and RH testing, this is review. We're going to test the red cells with anti-A1 and anti-B. The plasma is going to be tested with A1 cells and B cells. We're going to RH type them with anti-D. If the initial D test is negative, we're going to perform a weak D. We can use tube technique, solid phase, gel, and microplates. At the blood connection for our ABO and RH, we will use tube, microplate assay, and solid phase. We don't really use gel for our ABO and RH. For an antibody screen, this is going to detect unsuspected antibodies in the donor plasma, and it's designed to test for clinically significant antibodies. If a clinically significant antibody is found, the plasma and platelets are not used for transfusion, but we can be sold as source plasma, or plasma that's going to be going to make reagents or cosmetics or whatever. The RBCs can be used, but they must be clearly labeled. So we know that with these packed RBCs, there's sometimes residual amount of plasma in there. Usually it's not enough to cause any sort of testing discrepancies if they were to use positive antibody screen RBCs, but most hospitals don't use them anymore because they were discarding them. So we would send them out, spend all the time and effort and money it took to process and send it just to have them discarded. So most hospitals don't take them anymore. We will discard our RBC products as well that have positive antibody screens. With syphilis testing, rarely transmitted through transfusion. There's been no documented cases in over 40 years in the U.S. from transfusion. One reason is the spirochete can only survive 3 days in the citrated blood stored at 1 to 6 degrees Celsius. An RPR screening test is used for this, and what does RPR stand for? Rapid plasma reagin. It's confirmed by a fluorescent treponemal antibody adsorption test. At the blood connection, we will do the RPR test and do a titer on it to see like how much it's in there. We report that out as well. But then we definitely want to confirm it by repeating testing because you don't want to report out a false negative, or excuse me, a false positive. With infectious disease testing methods, we have enzyme immunoassays, or EIAs. An indirect EIA would detect the antibody. A sandwich EIA would detect an antigen, and a competitive EIA would detect either the antibody or the antigen. So if the principle of these enzyme immunoassays is you have the antibody and the antigen, you add an enzyme conjugated antibody which binds to the antibody antigen complex, and the enzyme on the antibody antigen complex uses a substrate to produce a color change to indicate positive. For the sensitivity and specificity, so sensitivity, again, is the ability of an assay to correctly identify samples from infected individuals as positive. Specificity is the ability of an assay to correctly ID samples from non-infected individuals as negative. EIAs are designed to have the highest possible sensitivity and thus may be less specific. Reactive samples are often repeated and a confirmation method is employed. Because they are so sensitive, a lot of times these will have false positives. So we definitely want to repeat the reactives and then we'll send it to another lab for confirmation just to make sure. With NAT testing, we have an amplification of nucleic acids of infectious agents. It IDs the presence of the viral RNA, such as HIV, hepatitis C, or West Nile virus. We can use polymerase chain reaction or transcription-mediated amplification, and it enhances detection during window periods. The engineering behind this is just so fascinating. Running the NAT testing machines isn't overly complicated, but just what they do as far as replicating this DNA, the transcription, DNA and RNA. They use magnets to coat these markers and they centrifuge, and I mean it's fascinating because I'm a blood bank nerd, but that's NAT testing in a nutshell. For hepatitis testing, donated blood is not tested for hepatitis A, D, or E, but it is tested for hepatitis B and C. These are transmitted by blood transfusion, parenterally, sexually, and perinatally. The 4 tests currently used for this is the hepatitis B NAT testing, the hepatitis B surface antigen, antibodies to hepatitis C, and the hepatitis C NAT testing. We have human retroviruses of anti-HIV 1 and 2 and anti-HTLV 1 and 2. This is the human T lymphotrophic virus. Confirmation is done by Western blotting, RIPA, or NAT testing. With West Nile virus, in 2003, it was an implementation of the NAT testing to test for West Nile. These are screened in pools of donor samples. So basically, you'll take your donors and you'll pull the plasma together. And if you have a pool that tests positive, then the separate parts of that particular pool are tested. So you may have, say, pools of 25. You get a donor, or you get a positive reaction there. Then those 25 samples are then individually tested. About the first time when I was working at the Blood Connection, working in the testing part of it, we had a policy in place that if we had a positive pool, then we, for the next 2 weeks, had to test individual samples. And for that summer, oh my God, it was awful because just when we would almost be in the 2-week window, we'd have another positive that popped up, and then we'd have to individually test again. And it was bad. And when you of course, going from pooling testing to individual testing, you are burning through reagents. And with this particular machine, we didn't necessarily pay for the machine itself. We paid for the reagents to use the machine. So they definitely got their money's worth that year. Again, going to coincide with the peak transmission of West Nile virus, which is late summer, early fall with the mosquitoes. For Zika testing, very similar with screening of the pooled donor samples, but Zika was implemented in 2016. So there's another safety measure in place called a look-back program. And so what this does is it identifies and notifies patients who have received seronegative, or that's saying negatively tested, or untested donor blood products from a person upon a subsequent donation is found to be positive for a viral marker. So in other words, donor comes in, tested, everything's negative, everything's all well and good, their blood went to whomever for whatever, they come back in, bam, they have a positive result. Could be hepatitis, HIV, HTLV, West Nile virus. So then we're going to look to see who and what their blood products went to between when they were negative to now that they're positive, and then we'll notify those patients to come in to be tested for this, just to make sure they didn't get, transfused to something with an infectious disease that may not have been strong enough to be tested by our machinery. Most of the time, these are also negative. We can also test for antibodies to CMV, the cytomegalovirus. This is usually performed on units that would be intended for neonatal populations or for immunocompromised populations. A lot of times they like to request O-negative CPDA1 units, just based on what the components are in there and the preservatives. We can also test for antibody to T. cruzi, that's for the Chagas disease, and we do NAT testing for parvo B19. This is the human version of the animal parvovirus, and it's normally performed on source plasma, not for all donors. So finally, we have bacterial contamination tests. In March of 2004, the AABB added new requirements for testing for bacterial contamination in apheresis platelets and platelet concentrates. This uses a similar method as used to test for blood cultures. This is because platelets are stored in room temperature. They must be cultured in these blood culture bottles because bacteria love to live and propagate at room temp. We also use diversion pouches during the collection to decrease the risk of bacterial contamination. This is going to divert the first few milliliters of blood to capture any skin contaminants. Just a little bit of extra information on this. Very soon, the AABB is going to come out with the newest recommendations for bacterial contamination tests. I believe it's going to drop in the fall. So we'll have to update this for subsequent classes, but it's going to include different ways to do blood cultures with anaerobic and aerobic bottles, ways to potentially extend the 5-day shelf life of a platelet, point of care testing for doing this. So all sorts of things involved that we're going to update, but nothing you guys particularly need to know because it's not going to apply to you just yet. But we've reached the end of this lecture. We'll see you on the next one.